Pleased to present the next session on the regulatory issues related to human subject COVID-19 research. And I'm very pleased to introduce our panel. Joining us today is Dr. Heidi Maloni. She's the Associate Clinical Director of the Multiple Sclerosis Center of Excellence East at the Veterans Administration Medical Center in Washington, D.C. She's an integral member of the neurology service, bringing subspecialty care to veterans with spinal cord injury and multiple sclerosis. In her role as chairperson of the D.C. Veterans Affairs Institutional Review Board, Dr. Maloni guides the IRB committee in understanding and implementing regulatory requirements in the protection of human subjects in research, while supporting both investigator-initiated and sponsored studies. Dr. Maloni is an adjunct professor of nursing at the Catholic University School of Nursing. Next is Jim Boscoe. He's the director of the Medstar Health Research Institute Office of Research Integrity. ORI is primarily responsible for the regulatory oversight of clinical and preclinical research for Medstar Health and coordinates the research project with other components of the Medstar Health Human Research Protection Program, as well as research operations. Jim is also the Medstar Health representative to the regulatory ethics knowledge and support component of the Georgetown Howard University clinical translational collaboration. Jim previously worked as an IRB manager with the Johns Hopkins University School of Medicine IRB. Prior to his work in research ethics and regulations, Jim was a board certified behavior analyst and has worked with children with feeding disorders, children and adults with developmental disabilities, and adults with substance use disorders. And finally, Dr. Yvonne Lau is the director of the Division of Education and Development at the U.S. Department of Health and Human Services Office for Human Research Protections. Dr. Lau received her medical degree from the University of Hong Kong and is a fellow of the Royal College of Surgeons of Edinburgh in the United Kingdom. She obtained her master's in bioethics and health law and her Ph.D. in bioethics from the University of Otago in New Zealand. So thank you all for participating and welcome. And if anyone has any questions, please feel free to put them in the chat box. Thank you. Now I will turn it over to Dr. Maloni.
Yes, I believe we're moving her up as we speak.
Okay, are you able to hear me?
Yes.
Oh, that's wonderful. Let me start my video. Excuse me for this glitch. So my presentation is COVID-19 in the year, and I talk about it as a year of opportunity. Now I come to this session wearing two hats, my IRB chair hat and my clinical research hat. And you'll hear me talk about both of those hats during this presentation. So I chose COVID-19, a year of opportunity, really when I put together this talk to address the question of how this research community had to pivot to accommodate COVID-19, I approached the topic with more of an optimistic view, rather one of making lemonade out of lemons. Let me continue. Do I do the slides? Excuse me. Yes. So as background, in March 2020, to prevent the spread of COVID-19, limitations on human interactions occurred inside and outside the research community. So the VA Office of Research and Development, ORD, that you've heard from already today, placed a hold on all ORD funded, non-critical, in-person human research studies. Subject interactions to include any in-person recruitment, any screening, and any research interventions and follow-up. Now, there were exceptions for enrolled studies requiring safety monitoring, such as drug studies, and any COVID-related studies were exceptions. So the DCVA, the medical center director and the R&D program issued a broader hold on all human research studies activities, on all activities. So, thank you. Resumption. Oh, excuse me. I'm still not, oh, there you go. The R&D program. So the steps, the R&D program at the DC placed this research hold on all non-COVID in-person research studies. And as I said, with these exceptions. So when we resumed research, there were lots of steps for resuming them. And these steps had a lot to do with when the District of Columbia might lift their restrictions for non-essential business, or the DCVA was able to resume inpatient visits for non-essential procedures and services. University affiliates, were they allowing research resumption? And then what was the ability to combine research visits with clinical visits? Our hospital services like the lab and the radiology service, were those services available for research? Could remote visits be suffice? And is there a COVID testing available for personnel? So the required steps, as you can see, the steps for resuming research required an assessment of risk and a plan for mitigating that risk. Just go one more. I'm having trouble advancing my slides. So we did this in phases. Specifically, I wanted to say that the risk was a concern for the impact on the medical center, patients, the personnel, the resources for reopening research, and you've all recognized that because you've all been in this boat. So the risk assessment included PPE, cleaning supplies. Gosh, it's even hard to remember back to the days when we were hoarding Purell, remember? And I remember when we had to sign out masks once a week. We're no longer there, thank heaven. I mean, we've come a long way since last March. But the DCVA and the R&D committee created a plan for reopening research in a phased manner. So we categorized studies as low, medium, and high risk. And the phase 1, low risk, meant that we would open up studies to researchers that didn't increase the footprint in the VA, increase the contact, increase people. They would be able to do research on inpatients or outpatients who already had visits at the medical center. So August 30th, 2020 was the start date for opening phase 1. Phase 2 were medium impact studies. Medium impact meant that these would be studies with one session, single person outpatient visits, or they would be multiple session, single person outpatient visits that would take place away from the clinical center in our research area. So those were medium impact studies. We were going to coordinate this with opening up of the DCVA to patients for 50% of our capacity. We have not come to phase 2 yet at the DCVA. Phase 3 is then multiple studies, multiple research, only visits in clinical areas, and the hospital would have to be open to 60%. Next slide. So precautions again for opening research were we wanted to know if we could have telehealth tools, anything that would mean aerosolizing blood and body fluids, but with centrifuging, any other aerosol-related procedures such as exercise studies. The PIs would have to assure safety procedures, training staff on proper donning and doffing of PE. All of this was part of our mitigation strategies. Next slide. So risk mitigation again, included PIs were able to provide PPE for participants and staff. Was there physical distancing? Was there proper cleaning? Was there enough supplies for this? Was there limited and unnecessary exposure to the rest of the hospital? So PI had to plan to communicate this risk and mitigation by developing their own plan, presenting it to us, and then we in turn were putting that plan into the ORD and the DCVA. So the next slide, please. So our PIs were pretty creative. So these were PIs that had non-sponsored studies, the PI-initiated studies. They amended their protocols to allow for study visits in order to meet their research goals. Their amendments for existing protocols allowed for remote consenting, remote collection of data, and what they would use for consenting, we have a My Healthy Vet, which is a secure, encrypted way of consenting a patient, so they use the My Healthy Vet consenting. There are encrypted emails where using Gmail with a special encryption where patients could take a photograph of their signed wet signatures and then upload those signatures to an encrypted email site. So PIs are very creative in doing things like that. Next slide. So one of the things, some of the protocols aimed to understand acceptability, utility, and effectiveness of remote research. And our group did this. We looked at telemedicine and multiple sclerosis during the COVID-19 pandemic. We looked at perspectives from patients, healthcare providers, and payers in the United States. So next slide. This was a qualitative study. It was conducted between September 2020 and January 2021 with people. The patients were people with MS. The participants were insurance payers, and they were providers throughout the United States, within the VA and in the private sector. So it was a broad study. It's aimed to better understand the perceptions and experiences of people with MS, their healthcare providers, and payers during this dramatic expansion of telemedicine during COVID-19. Next slide, please. So some of the themes we gathered, the basic themes were that this was a convenient platform. It was a platform that certainly improved access when we weren't seeing patients at all. We were able to see them through telemedicine. We discovered that there were some technical challenges, but there was ultimately a perception of the value of telemedicine. I'm just going to let you in on some of the discussions that we had with patients. So a neurologist said, or actually, I wouldn't say first, one insurance provider profoundly stated that telemedicine is the single biggest transformation in healthcare delivery in 50 years, and it happened in 4 weeks. And I bet you can all identify with that. Another neurologist said, hey, they threw us in the deep end, but hey, we could swim. Another provider wondered, hey, where is the playbook? How do we do this? How do we perform a neurological exam with telemedicine? And then a patient felt, if he can't touch me, how does he know what's wrong? Next slide, please. More patients chimed in. The visit should be just more than talk. You're doing just talk on telemedicine, which frankly wasn't true in the end because we were able to examine patients. My provider looked at me the whole time, and this was positive. Didn't look at her computer. There were no interruptions, no pagers, no computers. This person felt he was getting better value through telemedicine. Another person said there's a benefit, a provider said there's a benefit of seeing the home environment, seeing where the patient is, understanding who's with them, getting to know their pets, looking into their cupboards to see what kind of breakfast cereal they eat every day. So there was a lot of benefit to being able to take your video to the home. And then one provider said, gosh, I saw a patient in his car as he was stopping for milk. That patient wasn't taking the telemedicine visit seriously. And we did have that comment on both patients and providers' part. But the good news here is that the copays were waived for the most part. Licensing requirements were relaxed across state lines. So those were good things. Next slide. Here you're going to look at graphs, and in this graph shows the results of benefits and drawbacks of telemedicine, some of the advantages. So 90%, if you're looking at the advantages screen on the left, 90% thought better access for patients, 58% felt better convenience for providers, 30% lower costs for providers. They didn't have to staff an office. And 29% thought better interaction with patients. Other 29% also felt that there were other advantages, like meeting significant others and assessing the environment, like I mentioned. And then 2% felt that there were no advantages at all. Going over to the disadvantages column, 82% found more difficulty performing a full exam, 60% technical issues, 23% had concerns with privacy, 21% thought that there were high costs of delivering and no insurance coverage, or they were worried about insurance coverage. And in fact, I had a chance to talk to some of the providers at a local hospital here in the DC area, and telehealth visits were bringing in 80% of their usual cost of face-to-face visits. So they were taking a cut, but certainly, all in all, it was better than no visits, correct? And 2% actually found no advantage. So the next slide. Next slide, please. Or am I doing it? Can I do it? Oh, I'm sorry, we're here on the next slide. So this is an overall satisfaction slide. All these yellow bars really show you that overall, patients, insurers, and providers had high and somewhat very satisfied and somewhat satisfied results with telemedicine. So the next slide, please. So here you're looking at utilization, the use of telemedicine pre-pandemic and since the pandemic. The graph on the left indicates in yellow those who use telemedicine pre and post. And you can see pre-pandemic, it was just about even with people who didn't. But post-pandemic, no surprise, it really went up. And then on the right-hand side of the screen, you're going to see providers who use telemedicine. What percentage of their practice do they dedicate to telemedicine? And now it's a great deal. It's much, much more. You can see it's almost up to 100% with 80% being the median. In talking to providers in some of the DC hospitals outside the VA, they tell me even now, today, April 22nd, they are 60-40, 60% telemedicine and 40%. They can dedicate a day at home to do telemedicine. They can sit in the comfort of their home and they're not utilizing their car to get back and forth to work. There's a lot of economic benefits. If you think about it, there can be some economic losses for hospitals. Who's spending money in the cafeteria? Who's paying for parking? Who's buying flowers in the gift shop? Not the person in telemedicine. So there are some economic downfalls to it. Next slide, please. So in my conclusions, the COVID-19 pandemic was an impetus for using telemedicine for all of us. Convenience and flexibility are valued despite technical challenges. The technical challenges mainly were overcome very, very quickly because they had to be. Offices would call patients ahead of time, set it up, make sure patients had the right room that they were entering and they had the right technology in hand. Payers uniformly covered telemedicine encounters during the pandemic. There is an apprehension as to how insurance and government leaders will choose to reimburse in the future. So lastly, let's look at my last slide. I have some questions for you. Oh, I have some more conclusions, excuse me. Well, here are the questions, the conclusions. Yeah, the COVID-19 pandemic forced widespread utilization and reimbursement for telemedicine and relaxed legal policies that made it possible to implement them. Telemedicine is an efficient and convenient platform for many aspects of MS care and is supported by the majority of people with MS who we interviewed and saw, and their providers. So let's get to the last slide with a couple of questions. So overall, putting both of my hats together as the IRB chair and then as my research and clinician hat, the questions are the same. Is remote and virtual research here to stay? What are the disadvantages of remote and virtual research? And then of course, remote and virtual clinical visits. And then what are the advantages? So I put that to you to answer in the panel discussion. Thank you.
Okay. So I just want to say thank you for having me as a part of this panel. I wanted to spend a little bit of time, Mary did the introductions earlier, a little bit of time talking about the Medstar Health perspective on collaborating with other institutions and with our investigators throughout particularly the early days of the pandemic. I think if we can go to the next slide. And I'm going to start, I want to start that conversation with just a brief overview of the relationship between Medstar and Georgetown University for folks that may or may not be as familiar. I'll talk a little bit about how we generated and presented some joint guidance for our investigators. We'll talk very briefly about an adjustment we made to an existing study in the hopes of allowing the study to reasonably continue during the pandemic. And then the startup of a multi-site COVID-19 protocol that was a little bit unusual. And then I'll finish with some considerations for the future. I don't know that I have anything really terribly profound to say there, but just a few thoughts that occurred to me as I was working through this. So again, we'll start with working together. So the Medstar Georgetown University collaborations. And I think, I want to start with kind of looking at the Medstar Georgetown University Hospital. Obviously, Georgetown University's name is in the name of the facility, is included in the name of the facility, and it sits physically on their campus. So Georgetown actually retains oversight of research activity that's conducted at that facility, primarily to do things like ensure compliance with the Catholic directive. At the same time, Medstar is primarily responsible for clinical activities at the Medstar Georgetown University Hospital. So there's sort of a unique relationship there that presents some opportunities for collaborations, but maybe some challenges as well. So I think it's important to remember, although we're functioning in kind of the same space, we are talking about two separate institutions, and the two institutions have separate IRB systems. There are cases where the Georgetown University IRB will review for Medstar, and Medstar does occasionally review research that includes or that involves Georgetown University associates as well. So again, two separate systems, but there's some overlap there. And I think, again, that provides some unique opportunities for collaboration for our investigators, but maybe some challenges in terms of figuring out, who has oversight and where do I have to submit my application depending on what I'm doing. And that's where I think the collaboration between Medstar and Georgetown, in particular the IRB offices, comes into play. So we can, work as much as we can to try and harmonize our policy and procedure, but also it's important for us to communicate to our investigators where we're not able to harmonize, where things may be different, such as the requirement to, excuse me, to comply with the Catholic directive for Georgetown, but not necessarily for the rest of the Medstar facilities. So I think one of the examples of our collaboration came into play with kind of working through, like I said, the early days of the pandemic, where just like the rest of the world, we were suddenly hit with rapid continuing changes. So ongoing COVID-19 restrictions, such as social distancing, requirements for masking, limitations on things that can be done in clinical facilities, a mass shift to remote work, right? And things like that. And it was sort of our responsibility to look at these things and to help our investigators navigate opportunities to continue research where possible and reasonable. We also needed to kind of look at the guidance that was coming from the regulatory agencies, where they were describing situations where they might exercise enforcement discretion or other, presenting other opportunities for flexibility to continue research or to start new research specifically related to COVID-19. And I think from both sides, kind of the joint message from Medstar and from Georgetown to our investigators and our research teams was, one, don't panic, right? Which I think is generally good advice for life, right? Panicking doesn't really help. But, conveying the message that we're going to work through this together. We're going to work to understand your situation and help you understand what you can do to safely and reasonably continue. I think a reminder to be flexible, which is particularly important for those of us, I think, on the regulatory side, where sometimes we may put ourselves in too much of a box and be a little bit rigid. But, it's important to recognize that where it is reasonable and allowable, there may be some flexibility as long as we maintain compliance with policy and regulation. So I want to talk specifically about coordinated communication that was sent out from both Medstar and Georgetown University. And we did that, we kind of worked together to create a guidance document for our investigators. And I'm not going to go into a lot of detail, just in the interest of time, on what our specific guidance or recommendations were. I think the point here is to show the collaboration between the two institutions. And I put a screenshot of the top part of our guidance that we sent out to our investigators there, not necessarily expecting that you're going to get any reasonable information out of the tiny little text. but to demonstrate that we even went as far as to brand the document as coming specifically from Georgetown University and Medstar Health. So we were able to issue a single guidance document, which I think was particularly useful for our investigators that sometimes work in both spaces, right? So instead of getting two separate documents from the institutions and having to figure out where they match and where they're different, they got one document, and this ended up being about an 8 or 9 page document in the end after some successive revisions. So I think particularly relevant to have in one place. You know, these are the things that apply to both institutions. These are things that are specific to Georgetown, and these are things that are specific to Medstar. We included a table with some kind of general recommendations and then more specific guidance throughout the text of the document, including things like, you know, reminders to make sure you're following public health guidance and mandates, right? That's kind of paramount, and as well as institutional guidance and your facilities mandates. A reminder that the IRBs were still fully functional, right? We're not necessarily showing up in the office every day. We're going to our basements or living rooms or dining rooms or other places, but we're working remotely. We're here to provide guidance. We're processing applications, and our committees are still meeting. We're meeting virtually, but we are still meeting on a regular schedule. And again, we provided additional guidance on things like the need for protocol or operational changes, right? And where do things still need prior IRB approval before they can be implemented, or, you know, things like if you identify an apparent immediate hazard to participants, right? Can you act? What do you do with that, right? So maybe you can act immediately and then report that to the IRB later. If we can go to the next slide. One of the things I also wanted to highlight was a specific study, an ongoing study, and we can go to the next slide, where we were able to work with our investigators to allow them to continue to conduct the research. So this was a study involving participants with diabetes. It was an interventional study where participants were expected to continue to show up for study visits for a period of about 7 years, and they were typically coming to a primary care office, a Medstar primary care office. Well, it turns out this primary care office was immediately adjacent to an urgent care facility. And in early March of 2020, the urgent care facility started conducting COVID testing. So they had lots of people coming into that location who thought they may have, you know, they had symptoms that were consistent with COVID. And there was some concern about bringing these research participants with a diagnosis of diabetes to that location, and the possibility that they would come into contact with someone that was you know, potentially positive for COVID. There was also some concern for the safety of the research staff. So we discussed this with the study team, and they proposed moving the research visits from that location to a Medstar space a few blocks away that was primarily administrative offices. So there was no COVID testing. It was a lower traffic facility. It did include appropriate facilities to safely conduct the research visits. And it was determined that that would be a safer option for participants that wanted to continue to come in for the research visits, and it would actually be safer for the research staff as well. The other consideration was this was thought to be, it was going to be a temporary change, right? We didn't know at that point for sure how long this was going to go on, but it was going to be temporary. So the question was, do we need to really revise our protocol to address this, or is there another way we can handle this to do it appropriately? And since this didn't affect any of the study procedures, it didn't affect risk to participants other than presumably reducing the risk that they might contact COVID-19. We determined a revised protocol wasn't necessary. This could be reported to the IRB with a plan for communicating the option to come to a different location for participants if they choose to continue to come to their study visits. And then once we move past this period, then they can communicate back to the IRB that they're returning to their original plan. So it made sense. It was reasonable to provide some level of safety for the participants and to reduce the potential administrative burden for the research staff. One other example I wanted to go over was the Mayo Clinic expanded access for convalescent plasma protocol. And it's my understanding that FDA actually approached Mayo Clinic and asked if they would be willing to serve as a coordinating center and single IRB for this national effort. And the FDA actually approved some special accommodations for this protocol because they expected a large number of participating sites to show interest in the study. And as I understand it, they ended up with greater than 2,800 sites nationwide. So I think they were right on that point. There was also a sense of urgency to get this started, so this could be offered to people who are experiencing serious symptoms from COVID-19, so there was a need for a rapid startup. So some of the accommodations the FDA had approved for this protocol were one of the things that I refer to as an atypical documentation of reliance. So normally when Medstar relies on an external IRB, we would either document that through the SMART IRB agreement or through a standalone reliance agreement. In this case, the FDA had approved basically an online registration for reliance, right? So there was no exchange, there wasn't a typical exchange of information between institutions or IRBs. It was the clinician logging onto a Mayo Clinic website and essentially registering for the study. There was also somewhat more limited role of the local institution or the IRB in the reliance process for this protocol. In that, you know, Mayo initially indicated that a local submission wouldn't be required to Medstar. We eventually did determine we wanted to have it documented in our system just so we had record of who was involved on our side and what was happening. But from the Mayo and the FDA perspective, that wasn't necessary. There was also a mandate to essentially accept the protocol and the consent form as they were, which is a little bit different. You know, typically the local institution would have an opportunity to provide input on the consent form and maybe require some template language that would go into the consent form. In this case, because of the urgent need for a rapid startup, the large number of sites and limited resources, Mayo Clinic had mandated and the FDA approved that the participating sites basically either accept the protocol as they were and the consent form as they were, or, you know, don't participate in the project. So there was a lot of close real-time communication with our investigators on this to ensure, kind of to put them at ease and to make sure we were all comfortable with the arrangements and that, you know, everything was done correctly. And to also, to the extent that we could, to facilitate communication with Mayo Clinic throughout the process. And that's pretty much it. I wanted to just kind of leave with a couple of final considerations. You know, I don't think I have anything terribly profound or earth-shattering here, but I think, you know, one of the things I thought of, you know, throughout putting this together was clear and open communication was critical throughout all of this, right? Not only with our investigators, but in our collaborations with other institutions, with Georgetown, and particularly what I'm referring to here as frequent collaborators, right? And the need or the desire to harmonize wherever possible, and the need to clearly communicate to our investigators instances where things might need to be a little bit different or where we may not be able to harmonize.
Hello, everybody. I'm going to pick up from what Jim was just talking about in terms of flexibilities here. So my topic is leveraging regulatory flexibilities in the common rule. The opinions expressed here are those of myself and do not necessarily reflect the policy of the US Department of Health and Human Services. So I think I'd start by just providing a reminder here of how the common rule works, right? So the common rule regulatory requirements apply to non-exempt human subjects research funded by the Department of Health and Human Services and the other common rule agencies and departments. So regulatory requirements stipulate, amongst other things, the operation of the IRBs and informed consent requirements, etc. So in other words, what I'm talking about is that there is a strict set of criteria that needs to be, that institutions need to comply with when they're talking about an IRB full board review or expedited review, or the requirements that are needed to be put into the informed consent. So when these regulatory requirements do not apply, and there are situations where these many situations indeed, where these regulatory requirements do not apply, it means that investigators and institutions have the flexibility, especially with regards to how they review the study and what kind of consent that they do. So, what information they put into consent form, or whether it's going to be just a verbal consent, verbal type of agreement. So when the regulatory requirements do not apply, investigator and institutes have these flexibilities outside of the regulation. And we really highly encourage people to make use of those flexibilities. Now, that is not to say that investigators and institution would not need to pay attention to the participants' rights and welfare. At the end of the day, it's not so much just a case of complying with regulations. And when there are no sort of regulatory requirements, there's the flexibility. We still need to pay attention to how we conduct research and keep participants safe and protect their rights. So we just talked a lot about when regulations don't, or the requirements don't apply, there'll be flexibility. So let's look at the situations when the regulatory requirements do not apply. So first of all, when the research does not receive federal funding from a common rule agency or department, it may not need to comply with any common rule requirements. So look at the funding, right? If the funding is not a federal funding, there's the possibility that there may be a lot of flexibility for your institution. Of course, many of you who are in the IRBs and work in compliance, that there is such thing as something called checkbox when institutions file their federal-wide assurance with OHRP to assure the federal government that they would do research by complying with the regulations. Now, some institutions voluntarily check this box to apply the regulations to all their research regardless of funding. I want to emphasize that this is done voluntarily. It's not an OHRP requirement. OHRP does not encourage institutions to do so. I want to tell you one more thing is that if your institution did check the box, and now hearing what I'm saying here, that this is not a requirement, this is not something that OHRP encourages institutions to do, and you want to go and make use of this flexibility, you want to go back in and uncheck the box, you can do that anytime. So, there are other situations where the regulations actually do not apply. As you know, if the entire human subjects research study fits into conditions of one or more exemptions in the common rule, and I'd like to remind everybody that with the revised set of common rule, the exemptions have actually expanded tremendously. Just take exemption 2, for example. So many studies now, if it's just interacting with participants or doing a surveys or completing an online survey, that sort of thing, basically you could use the exemption even if the interview or the survey questions involve sensitive type of information, and even if identifiable information is included. All you need to do is just go through something called a limited IRB review, which verify that the conditions for protecting privacy and confidentiality are there. So the exemption 2 has expanded a lot, and there is a new exemption, the exemption 3, that allows people to actually combine sort of something like a written survey together with a benign behavioral procedure. I can imagine, for example, in the COVID situation, there may be researchers who want to test certain health promotion material, resources, to see if that would change people's behavior, that would make them more ready to participate in vaccine trials or just accept having the vaccine. So again, this type of sort of behavior changing type of procedures or interventions can well be considered often under this exemption 3. So please make use of these exemptions whenever it's suitable. Of course, the research could also be not human subjects research, and that would make it outside, the scope of the common rule regulations. Situation typical of that would be, secondary research using non-identifiable data or non-identifiable biospecimens collected from. So secondary research would be, materials that are collected from non-research purposes or for research that is not the current research, right? So by all means, make use of these flexibilities. And Under the revised common rule, of course, you could also have study that could be accepted, excluded from what is, what our definition of research is. The one that comes to mind is the public health surveillance, which is a new exclusion in the revised common rule. Just to say a few words about this, so what are the excluded public health surveillance activities? These are activities that must be conducted, supported, requested, ordered, or authorized by a public health authority. I put that in red because it's really important. You kind of, if you are doing one of these studies, it would be a mandated and, from a public health authority. And there is a definition of what a public health authority is. And they're limited to activities that are those necessary to allow the public health authority to do the following activities. So to identify, monitor, assess, or investigate potential public health signals, onsets of disease outbreaks, or conditions of public health importance. So there is a kind of understanding that these are things that are necessary to respond, right, often to something like a COVID. Let's take an example to illustrate when that could apply. So the public health authority authorizes general screening for COVID-19 for public health surveillance purposes, and then requests that the test results be shared as necessary to allow the public health authority to identify, monitor, assess, or investigate the COVID-19 outbreak. So first of all, we have public health authority authorizing, and then secondly, we have, a clear description of what the purpose of doing something is. And if, an investigator is asked to participate in this and they incorporate these activities even into their existing research study visit, they can do so without prior IRB review and approval, because this set of activities are excluded and is under the public health surveillance exclusion. With that, I'm going to move a little bit away from that topic and go into some of the flexibilities that are allowed in the informed consent process. So if you are dealing with incapacitated subjects, don't forget that consent can be obtained from the subject's legally authorized representative. And this is a concept that is familiar to many of us in the medical field. What is new in the revised common rule is that now if there's no applicable law on what an LAR is, this can be an individual recognized by institutional policy, right, as acceptable for providing consent in the non-research context on behalf of the subject to the subject's participation in the involved in the research. So the common rule has made it clear now that, if you have institutional policy describe, who can actually provide consent for certain procedures, you can utilize that also. When consent cannot be obtained in person and can only be done remotely, which was often the situation as we've seen in the past year or so. So the first thing to do would be think about whether your research actually could benefit from the flexibilities that we just talked about. For example, can the research actually be done under exemption, right? If it can, then you have all the flexibility in the world as to how you actually want to conduct the consent process. Next, you can also think about check with the IRB to see if informed consent can be waived by meeting the conditions in the at 46.116F, where it talks about the waiver of informed consent. I'm not going to go into that. And so if you can't, and you have to, get consent like in the usual manner, so start thinking about, okay, how you provide a digital copy of the consent, done electronically by phone, email, and some of the web links and other methods that we've already talked about earlier this morning. Make sure to include means for the subjects to discuss the study. I think this part is really important to emphasize. So often, we remember, and we, find a way of, sending the consent document to our subjects, but we kind of, forget to include an opportunity, instructions as to how they can, what means they could use to actually discuss the study and ask questions. And that's really important. The next thing one have to think about is consider how to facilitate the subject signing and returning the form, right? So there is a waiver actually in the regulations, the waiver for signing, waiver for documentation at 46.117, and that's available when the consent form is the only document linking subject to research and the principal risk of harm results from the breach of confidentiality. Or when you're talking about a really minimal risk procedure that only involves procedures that do not normally require written consent, right? So think about how, you know, those procedures that are involved in the research can fit into some of these conditions, and then you can have the IRB, you know, request the IRB to waive that documentation. Then you don't have to think about, you know, subjects could sign it. And of course, last but not least, if the subjects need to sign that, you can't use a waiver and so on. Think about electronic signatures, right? And these could be digital signatures, username and password, combinations, biometrics, etc. They are permissible, and it's very clearly indicated in the revised common rule now. In the pre-2018 common rule, it's the same. It's permissible. It's just not clearly stated, but now it is in the revised common rule. So make sure that they are legally valid within the jurisdiction where the research is conducted. That's the thing that you need to be aware of. And so check the state and local laws to understand what is permissible. So again, don't forget, whether consent is obtained in person or remotely, subjects or the LAR must have sufficient opportunity to discuss and consider whether or not to participate in the research. And unless waived, the subjects need to be given a copy of the consent documents, have a signature on that one. So I don't have a lot of time left, and since Jim have already covered some of this about IRB reviews. There are flexibilities there, so talk to your IRB about it. Don't forget, for investigators, you can submit your changes at any time to the IRB for their review, and if it's minimal, minor changes, IRB are really, you know, encouraged to use the expedited review process. In terms of full board reviews, the format of the convened meetings, you can do that. They don't have to be in-person meetings. You can do that remotely, virtually, by phone or online. Just make sure that quorum is maintained throughout. So quorum could easily be lost if your members attending the meeting, you know, become temporarily unavailable. So they go in and out or something. So just make sure that everybody is present and available to discuss the research. And eliminate the need for continuing reviews by using the expedited review mechanism when you. And I want to just spend a few more seconds to talk about the OHRP initiative, the About Research Participation Initiative. You can see our website there. Earlier presenters were talking about engaging the community and making sure that people understand and spending time to explain what clinical trials are and what placebo means, what randomization means. I want to just encourage people to utilize these resources that are on the About Research Participation on OHRP website. We have spent the last 4 years developing materials that are tailored for the general public at, you know, at a level of language where, you know, the general public would understand. So we develop these materials really from their perspective. All this information is available in English and Spanish, so it's already there. I want to just give you an example. So apart from, you know, videos on clinical trials talking about randomization, placebos, we've also added a new video recently, research with children, what parents need to know. So we've started, you know, doing COVID vaccine studies involving children. And then we have other videos and materials that resources that other, you know, research organizations might not have thought about including. So we've developed things on protecting privacy in research, telling people about how that's done and what they need to be concerned with, and other things like, you know, research with medical records and samples and participating in social and behavioral research and so on. So please do visit us and utilize these informational resources. And if you need to, you know, get the source files from us, we are very happy to provide them to you so that you could incorporate on a TV screen in your clinics, and however you want to make use of them. With that, I leave you with the contact information for OHRP and some of the resources. I want to point you to the joint guidance between OHRP and FDA on the use of electronic informed consent, questions and answers, so that, you know, this is a document that you can refer to, and it provides a lot of useful answers for information on electronic consent. Thank you very much for your attention.
Thank you very much for this very informative discussion. All of your slides were great, and we very much appreciate that. We are running a bit over, and so I wondered if the panelists could answer the questions in the chat. There are a few questions there. And now I'm going to turn it back to Sheila Garrity for the closing.
Thank you, Mary, and thank you to all the panelists today. I am always nervous when we put these conferences together and then so relieved and impressed. So thank you for your participation, audience, panelists, organizers. Hillary Dolinsky, who's behind the scenes and keeps us all on track, is kind of an unsung hero, and we all appreciate her. Hope to see you next week. Here is the, you will receive an evaluation link in your inbox. We will share the slides. Thank you all, and I will see you next week. Should I keep talking, Hillary? Nope, we're done. Thanks, everybody.